Okay, I guess we can start. So thank you all for making it to our prescription med disposal in service training. Just for your attention, this in service is being recorded and the link to the video will be shared to every participant after the in service. For those who don't know me, my name is Kima Boswa. I am the extension specialist for OCS Solid Waste Program. Today we have two amazing speakers, which I'm pretty much excited about. Courtney from RASUT and Amanda from the Oklahoma Department of Environmental Quality. But before we kickstart the training, I would like them to introduce themselves more. So I'll start with you, Courtney.
Hello, so I'm Courtney Redding. I was born and raised in Stillwater. I'm a pharmacist for the last 12 years. I went to undergrad at Oklahoma State University and got my biological sciences degree from there, and then went on to the University of Oklahoma and got my PharmD from there. So I have two different pharmacies. I'm a co-owner. So we have Razuk's Drug that we purchased in 2011, and then Allen's Pharmacy, which we purchased in 2017.
Great, thank you. Over to you, Amanda.
Hi, I'm Amanda Schofield. I work at the Department of Environmental Quality in Solid Waste and Sustainability. I went to Oklahoma State University and got a degree in Natural Resource Ecology and Management. Excited to be here. Thanks.
Great. Thank you, ladies. Okay, let me see if I can share my screen. Can you see the slide? Okay. Okay, so as we all know, today we'll be learning more about prescription medication, its disposal, and some of the risks of improper disposal. So prescription medication basically are drugs that legally requires medical prescription before one can take it. And examples of such drugs are opiates for pain relief and depressant to help with anxiety and sleep, and also stimulant to help with attention deficit hyperactive reactions and things like that. So in most cases, these drugs are helping relieve our pains and help with health issues. But in most cases, most of these medications are not fully taken. And this can be as a result of either allergies or maybe side effects from taking the medication, or maybe change in therapy, or maybe the patient's health improve before they could finish taking the medication. And expiration dates can also be another reason why prescription medication are not fully taken. And sometimes the death of a patient will eventually stop them from taking the medication. And most of these leftover medications and expired medication are also not properly disposed of. Either sometimes the patient or the person in possession of the medication really does not have knowledge about proper disposal opportunities in their community, or maybe there is no disposal option at all. And there are some who are just maybe lazy to drive to drop off location, to drop off their medication. So what they will do is maybe dispose of it in their household trash, or some might easily flush them down the toilets or pour it down the drain. And some might even decide to burn it alongside some other household trash, which is illegal to do. and some might just also don't just dump it around their community, and all of these are not good for the environment as well as for, or will pose some public health risks, which Courtney and Amanda will throw more highlight on today. So with that, if you have any questions for me, feel free to drop them in the chat box. And also after Courtney's presentation, if you have any questions for her, feel free to drop it in the comment box, and same applies to Amanda. They will get them answered for you. So I would take it over to Courtney. And let me stop sharing.
Okay.
Okay, like this.
Okay, let me try to share mine real quick. Hold on up. Okay, can everybody see that okay? Okay. So I am going to be talking about specifically prescription drug abuse and misuse, and then also going through the drug take back program. There's a couple of things that I would like to cover. So specifically drug abuse and misuse in Oklahoma and the United States. I'm going to talk about changes in the pharmacy world in the past 10 years. We're going to talk about the drug take back program on a national level. And then I'm also going to talk about the drug take back program in our own pharmacy, Rizux drug, that was started in 2017. So first, let's define prescription drug abuse and misuse. Drug misuse is the use of illicit drugs and the misuse of prescription drugs. Of course, this has been a long-standing problem in the United States. Drug rates of misuse have increased a lot in the past 2 decades, and this results in a significant loss of life. It has a big effect on society as a whole, and it's also very expensive. The federal drug control budget for 2019 was over $36 billion. National trends, of course, these have increased. And if we're looking back at 2006, so I'm looking back at when I first started pharmacy way back in the day. So 2006, most of, or 1/3 of new abusers were between the ages of 12 and 17 years old. Teen abusers usually use more prescription drugs that they abuse instead of illicit drugs, not including marijuana. And then the important statistic that we'll keep on coming back to is that 70% or most people that abuse prescription drugs get them from friends or family. On an Oklahoma standpoint, again, looking through my career when I was initially a pharmacist, starting out in 2012, Oklahoma ranked #1, yay, nationwide in painkiller addiction. We were #5 nationwide for deaths associated with drug overdose. We were also 5th for the number of painkiller prescriptions written. Of those that abuse painkillers, 1 in 5 of those are actually getting the prescription from their prescriber. Again, going back, most people are actually getting them from friends or family members, either being given it to them or taking it from them. 2013, 9.6 million prescriptions were filled for controlled substances in Oklahoma, and our population at the time was only 3.85 million. So we had 195 dosage units or tablets, pills for everyone in our state. Very high. If we're looking at the rates of overdose deaths between 2003 and 2017. Forgive me just a second. We have chickens that are clucking outside. I'm at home. So if you hear that, I apologize in the background noise. Okay, so 2003 is on your left. These are the rates of overdose. Of course, that has increased substantially looking forward to 2017. So this is your nationwide trends. If we want to look specifically at Oklahoma, we are in the gray, which looks not as bad, but we had 775 people in our state in 2017 that died of opioid overdose. Our mortality rate was 20.1, which was slightly lower than nationwide, which was 21. If we look at our most current death rate for our state, it has actually decreased to 18.4. That's per 100,000 people. So we're doing some things to help reduce the number of deaths associated with drug overdose. So specifically in pharmacy, I like to look up what are we doing or what have we done in the past 10 years to hopefully decrease this rate. The prescription monitoring program is a huge thing that we have done. It's actually an electronic database that we've used. This was started actually in 1991. So great thing that Oklahoma has to offer. It actually went on a web-based system in 2006. We didn't have access to this as a pharmacy until much later, though. It's actually a real-time database that we use. So as soon as a prescription for a controlled medication is filled, then it is automatically uploaded onto this database, and the doctor, prescriber, pharmacy can see who the patient is, what did they get, what was their day supply, who prescribed it, all of this really great information. So you would think with this all being at our fingertips that we would utilize this more, but in a poll done in 2013, only 1 in 6 prescribers regularly checked their PMP. So we had a big problem there. So what happened was in 2015, Oklahoma lawmakers actually mandated the use of the PMP system to prescribers. So now prescribers are required to check PMP before they're prescribing opioids like your pain medications or benzodiazepines, including Xanax or Valium, those types of things, or carisoprodol. So carisoprodol is actually a muscle relaxant, if you don't know that medication. The combination of opioids, benzodiazepines, and carisoprodol is considered what they call the Holy Trinity. Those 3 together, you have a much higher risk of patients overdosing or having negative side effects with those 3 things. So that's one reason that we're checking those. Before we had access to the PMP system, I'll give an example of what our daily life looked like in the pharmacy. So I had a patient come in one time, Arkansas patient, Arkansas license. He's filling a prescription that's from Florida, and he's in Oklahoma to fill the prescription. Of course, this is oxycodone. I think he tried to throw me off with a prescription of ibuprofen 800 just in there. We had Xanax and a muscle relaxant. So all 3 they're trying to fill in our store. We have no way of knowing at that time, have they filled it somewhere else? How do we verify the doctor? So of course, we try to contact the doctor. We find out that this prescriber is actually selling their scripts. When we find out in the long run, the doctor was being investigated by the DEA. Of course, we refused to sell the prescription. Those people were arrested. But it was actually, you think that would be like, oh, this is this doesn't happen that often, but at that time we were getting a lot of people that were coming in with trying to have fake scripts with us. Another example after we initiated PMP is that we had one patient that had 2 different IDs that they used. So you could use your social security number, and you could also use your driver's license to fill your prescription. Like you can use either one for the PMP system. And somehow this patient had their name spelled 2 different ways in on their driver's license and their social security card. So once we kind of got into it, we were always getting their social security card. So we were always filling the prescription. They're always showing their social security card. One time they gave us the driver's license and we're like, wait, this is spelled differently. So then we get in and we realize once we're in the PMP system, this patient has 2 different profiles. One where they're filling all narcotics under the social security number, the other one where they're filling all these different narcotics under their driver's license. So PMP was able to merge it with Oklahoma Bureau of Narcotics. This person is now also in jail. And so it's those parts, like I feel like we're getting some of those people off the street that are intentionally trying to divert medication, sell medication that they're getting. So I think that this has been a huge resource that we have in the pharmacy world. You can see, because of that 2015 mandate where you have to check in our state, check the PMP, I feel like it had a big impact on prescribing trends. Nationwide, you can see that these have decreased overall anyway. So looking back at 2009, going to 2019, overall as a nation, the amount of opioids that we're prescribing has definitely decreased. This is from many different reasons, not obviously just PMP. We have nationwide acts and mandates that have gone through. Each state is doing their own battle, trying to reduce prescription opioid prescribing. In Oklahoma itself, I do want to mention a more recent thing that has happened is that and now in Oklahoma, we can partial fill C2 prescriptions. So that's opioids or think of your stimulants like Hema was talking about. So Adderall, Vyvanse, things to help you concentrate, which I really do feel like is a great resource that we're going to have in the future. If you look at even with myself, when I had my son, you're given a prescription of like 30 Percocet as soon as you get out of the hospital. I'm probably not going to use 30 Percocet, but if I don't fill all 30, then what if I really do have a problem? Then I just partial filled it before, the rest go away, and I'd have to contact the doctor, try to get more. So this is not just my way of thinking. Lots of patients had that same way of thinking. And so then you end up, like Hema was talking about, you've got all this extra medication that's on the shelf that patients really don't need. So hopefully with this new ability for us to actually partial fill a prescription, maybe we can not have as much of the control medications that are just sitting there waiting to be either given to a friend or relative or needing to be destroyed. Another thing in the pharmacy world that has made a big impact is electronic prescribing. I love this. I don't know how much prescribers love this, but a electronic prescription is one that they automatically send over. Before, you would have your prescriptions handwritten. For control prescriptions, this posed a problem in making sure that the prescriptions were valid. If you had your own doctors that you were very comfortable with, you knew their signatures. I mean, we became really good at saying, this doesn't look like Dr. So-and-so's signature, we're going to call and verify. But we spent a lot of time trying to make sure that there wasn't fake prescriptions being sent through because of just prescription pads that were being taken or people that were just printing out medications. I have one example of a fake prescription that got by me. This was, let's see, before PMP. So it's probably or maybe when it first started, so 2015, I'm going to say, we had a customer come in. Of course, it's after 5 o'clock. So the doctor's offices are closed. It's a Friday afternoon. They come in with a prescription. We just moved to Stillwater. We're so happy to be here. I'm on chronic pain medication. But of course I'm out, and, I won't be able to make it through the weekend. Had a great story. They looked like someone that you could really trust. And of course, so you're thinking, okay, the DEA matched up. This is a valid prescriber. Everything looks good, except that the logo is slightly off and to the left, but maybe they just had a printing issue with the script pad. We went ahead and filled that prescription, and it was fake, but that patient comes back in 28 days, which is our standard for our pharmacy. If you have to wait 28 days before you can get the next refill. So this person walks in and he says, "Hey, I remember you." And I said, "I remember you too." So he gives me again a copy of the fake prescription. I now know very much so that it is fake. I'm working with another pharmacist at that time. We're able to kind of slow things down. The police are called. This guy was a runner. He ran out the front door. The police had to chase him down, but they did catch him. So one less person that was trying to pass fake scripts on us. But now that we have e-prescribing, the amount of energy that I'm spending trying to check on this is so much less, because I have an electronic prescription that's coming through actually from a doctor's office. The doctor themselves have to sign off on it. So, and on my side, I love the e-scripts. They've really helped as far as the diversion part's gone.
Courtney, sorry. For some reason, I don't know why my Zoom is telling me that the meeting will end soon when I said it's 1 hour.
Okay.
Till 12, so I want to check on something quick.
Sure, I'll wait. Do you want me to continue while you check on it, or do you want me to hold on?
Courtney, it
Yeah.
was fun when you said that you had chickens outside. I have chickens too.
Do you? They were being so loud. They were like, and I'm not at home super often. So I was like, gosh, they're just very happy out there, squawking away.
Do you have roosters?
I don't. I just have the hens. Do
I
you have
think we
roosters?
can just go on. I don't know.
We can go on.
Yeah, I don't know what happened there. It's just crazy.
Okay. All right. So I'll move on to Centers for Medicaid Services. So these are some big changes that CMS has implemented that I hope will have an impact on the amount of prescription drugs that are kind of out needing to be destroyed. So one thing that they've initiated is the 7-day limit for opioid naive patients. So now if you have surgery or if some sort of acute pain event, you are limited to a 7-day supply of opioids from a prescriber. The prescriber can write for more, but usually they have to explain why the patient would need to be on more. Usually it's honestly just easier if they write the 7-day and then write an additional prescription if they need it. The next act also, because now we can partial fill prescriptions, it makes it a lot easier if we need to just do a smaller quantity. Also, they've had to start doing or looking at the morphine milligram equivalency. So limitations to 90 milligram threshold. Typically, patients that are over 90 milligrams of morphine equivalents a day have a higher risk associated with them. So this flags the prescriber, saying this is somebody you need to look at. Not necessarily that they're trying to abuse medications, but they have a higher risk of having overdose with it. So it's not a prescribing limit. I also do want to mention that you have patients that are on chronic pain medication that need to be on chronic pain medication. And we have a stigma associated with that some people really do fight with, that are on chronic pain medication. So you do feel for them that they need help, and sometimes it's hard for them to get it. But this is not a prescribing limit. This is just another tool that Centers for Medicaid Services is using to try to limit the amount of opioids that are out there. The last thing that I want to mention on this part is the co-prescribing of naloxone. You might know it as Narcan. There's several different products that are out there that have naloxone as their active ingredient. This is a wonderful tool. In pharmacy, we're now able to dispense naloxone without a prescription from a prescriber, so we can prescribe it to them. So if it's somebody that's on opioids, especially on a high amount of opioids, over that 90 milligram for sure, then you want them to have that in their home in case there is an overdose event, that they would be able to potentially save a life. This is definitely a life-saving medication. The limitations with naloxone, though, are that it's pretty expensive. So sometimes before insurance companies wouldn't cover it, the patient was required to pay for it out of pocket, and it wasn't cheap. And so a lot of times people would say, no, I'm not going to have it, on the off chance that I won't have an overdose. In 2020, insurance companies are now required to have at least one naloxone product that is considered a non-branded tier. So, and what that means when you're looking at insurance companies, you have several different tiers. You have your generic medications that usually have a lower copay associated with them. You also have your brand name products that usually have a higher copay associated with them. So if we're looking at a non-branded tier, then it should be a cheaper option for the patient than that higher payment type. I personally feel like we can do a lot better with this as a state and a nation. If I was going to write a law or write something, I would say, let's make it where it's actually covered 100% on the patient's plan. If they're on chronic pain medication therapy, doesn't it make sense that they would be able to have this one-time approved 2 fills in a year to help save lives? I think if we're looking at our overall cost of healthcare, that this is actually would be saving money overall than costing more money. So if anybody is deciding to write a law for our state, or is going to be talking to their local representative, bring that up, because I think that it would be very helpful for our state and nation. Last thing that I think that's been a big change in pharmacy is the drug take-back program. So this started with the Secure and Responsible Drug Disposal Act of 2010. It's allowing patients to deliver unused pharmaceutical substances to an appropriate entity. And that appropriate entity has kind of changed over the whole life, I guess, of the drug take-back program. So October 2nd, 2010 is when I found that the first prescription drug take-back campaign was. At that time, they had 242,000 pounds of prescription drugs that were turned in for disposal. That's a pretty good kickstart to a program, I think. In Oklahoma itself, we had the Safe Trips for Scripts prevention program that started in 2011, and also referred to as a take-back box program. Currently, OBN, which is the Oklahoma Bureau of Narcotics, maintains 181 take-back boxes. These are really in law enforcement agencies across the state. We obviously have seen a huge increase in these boxes or take-back programs across our state and nation, and great things that Kima is doing on working at getting those medications out of our homes, off the street. So lastly, I want to talk about our pilot program at Rizux Drug. So this was in 2017. We started a 6-month pilot program, went from January through June. It was with Oklahoma State University and products. So we were talking about the pilot program with Oklahoma State University, Product Steward Institute, and Rizux Drug. So going back, this was a pilot program that was 6 months. At that time, they provided the receptacle that we could use. We didn't have to pay for the boxes that were sent back, the shipping cost at that time. And then after the 6 months, we got to decide if we wanted to continue this program or not. So that's kind of how it was presented to us. At the beginning of this program, I really honestly am embarrassed to say now, looking back at it, but I had a lot of concerns about doing this, and I didn't really know if I wanted to starting out. She really had to talk me into it. But my initial concerns, one were for the safety of our facility and our staff. Talking back at some of those things that we've seen patients coming in trying to divert medication. It's in a pharmacy, you always have that in your mind of, is this going to put us at increased risk of being a target of someone wanting to come in and steal medications from us? I also I didn't really know if it was something we could do in the pharmacy world at that time. Is this approved by my state board? Am I allowed to do this from the DEA standpoint? So we really had to look into that part too. And the third thing was really cost. I'm a small business owner, and at the end of the 6 months, what kind of cost is this going to regularly be for me? Is it something that I can afford to do for my community? The interest in the program, obviously, it's a service to our customers in the greater community. We're increasing foot traffic into our pharmacy once we get people inside. Hopefully we can show them we're really nice. We want to take care of you, and then opportunity to gain hopefully new customers from that point. The initial steps were much easier than what I thought they were going to be. I would like to say also 2017 was the year that we were purchasing our second pharmacy. So we were like, oh, if it's something that's going to take a lot of effort, I don't know if we have it. But it was modifying the DEA registration. So really actually easily done. We went online to their website where it was easily able to change our DEA registration for the pharmacy. We had to order and install the receptacle. My husband, which you saw walking by, at the beginning of my presentation, he was he's a good guy. He came into the pharmacy, jackhammered the bottom of it in there so it can't be easily removed. It's there to stay for now. And then we wanted it someplace that was going to be secure. So obviously we didn't want this outside the pharmacy. We wanted it inside, and we want to make sure that eyes were on it at all times. We also went through some staff training. So monitoring the receptacle. In my mind, when I first started this, I'm like, somebody's going to stick their hand down that receptacle and try to pull meds out. Nobody has done that, but that was like an irrational fear on my side. We also had make sure staff knew about documentation. So always making sure that we're doing things in a way that doesn't put anybody else at risk or saying that they did something they didn't. So always having 2 people present when you're opening up the receptacle. Everybody signed off on. So those were some of the things that we went through. Cost of implementing the program. So rental for one of those boxes is about $250 a month. We can purchase the receptacle itself. So at that time, it ranged from $700 to $1,000 to buy the receptacle. And then you've got these boxes and liners that you're purchasing from this company. You have a 36 months contract that you're entitled to. And then you would pay per month, or you would pay per bundle. So if we're looking at an average cost of that box and liner, it's like $200 once it's filled to send off and ship off. So, I mean, that is an additional cost for our pharmacy. The outcomes that just our store has done, because obviously we decided to continue past the 6 months. We've done pretty well that first year. You can see we're about 275 pounds of product that was destroyed, substantially continued to increase. We were just under 400 pounds in 2019. 2020, what can we say? We all know it was a crazy year. The front end of our store was closed down for several months, where we were just doing things by either delivery, drive-through, curbside, and getting medications to patients that way. We were not accepting any drug take back at that time because, especially at the beginning, we didn't know how long is this virus going to live on stuff. So I feel that if we took out all of that, if we took out the pandemic for lots of things, our numbers would look different. So it'll be interesting to see 2021. So far, we continue to have people coming in and disposing of medications. At least several times a week, I have people that I don't know that are coming in and dropping off medications. So I feel overall that we've made an impact as our little pharmacy that we can, that people are using it and are being more aware that it's there. So trying to keep getting the word out. My closing thoughts. So this is a local pharmacist impression on the fight against opioid abuse. I think that really we've come a long way. Looking at where we started back when I first got out of pharmacy school to today, I have customers, patients that are clear-eyed. Now I can have conversations with them. We can have interactions, whereas before they were in a fog and a haze. So I feel that we've personally, for each one of those people, they've made huge strides. Also, as far as us as individuals, I think we have different tools in place now that help us to prevent some of the people that don't need that medication from getting the medication. And then my perspective on the local drug take back program for our pharmacy, I think it's been a real success. I think it's those positives that I've seen or that I was thinking of when I was weighing the pros and cons have definitely come true. We have more people that are coming into the store. People are using it to get rid of medications that are on the shelf. I wish it was, we're not allowed to look at what they're putting into that receptacle when we help them or if they're getting it out. We see a lot of OTC products, which I'm happy for them to get those out of there too. I hope that a lot of the control stuff is actually getting in there as well. Though I think we could do more. I think if more people were aware of it, more big events, we can obviously get some of these medications that don't need to be out in the public, off the streets and out of homes. And that is my whole presentation. Any questions? Are we diverting questions to the end, Kima?
Oh, yes.
Okay. And then if anybody wants a list of my references, just let me know. I'll be happy to send them to you.
Okay. Any questions for Courtney?
Do you do much work with those groups that have the free Narcan or naloxone that you can sign? I know we have Wichita Mountain Prevention down south where I am, and there are different places set up that you can go and just fill out a form and get a free thing of Narcan. Do you work much with them?
I don't, though I would love to know their name, because that would be something I'd be happy to coordinate with them.
I can't remember it off the top of my head, but I will look.
Okay, thank you. Let me know.
Okay.
So Courtney, how do pharmacies know about the take back program that they can sign up for them? I know here in my county, we have a box at the sheriff's department and the police department, but I'm not aware of any of the pharmacies being involved. So how do they get involved?
So really it was a reach out from the Oklahoma State University, how I got involved, because I wasn't aware. I mean, this has been something that's been available, obviously, but it wasn't high on my radar screen that it was something that I could do. So I don't know if as many pharmacies realize that it's an opportunity. I think that it's, if you're looking to try to increase the amount of boxes in your county, that you would, I mean, it's a good thing to go and talk to your local pharmacies, because especially the smaller ones, they want to be able to help their communities. So.
I noticed, I'm in a rural county, Okfuskee, but I first heard about pharmacies taking back medicine a few years back. Shawnee at that's the one by the hospital, the Shawnee Pharmacy. They would take back, I took them a sack of medicines and they would take back, you know, the antibiotics and things like that, but they would not take back the opioids. But they told me about the boxes that were at the police station and and we have one at the courthouse here in Okemah.
Okay.
But the last time I checked and gave some, it was full. They hadn't been able to come out and unload it. My question is liquids. And y'all might address this, liquids and sharps. What to do with those? The cough syrups, the insulins. You know, you can't put those in the boxes. So hopefully y'all will address that later too. Okay.
Okay. You're right. There are some limitations. So our box, we are able to do control medications, but that's because we did, we changed our DEA status. So we actually went into online and reported that we were going to be doing a take back program so that they could monitor that. So that's how we were able to destroy the control medications. But we can't do aerosolized things. So the inhalers, we can't do those. Insulin is not as much of an issue, but sharps in general, we can't put sharps. People can't put trash in there. But I think sharps disposal is a whole different range of problems that, because that's an additional cost, and pharmacies aren't wanting to take people's sharps because you have to pay for that destruction. Also, some hospitals are offering that to the community as an option, that they'll destroy people's sharp containers. But I mean, we really don't want this ending up in landfills. So that's a whole nother realm.
Okay. Any other question? Oh, well, thank you, Courtney.
Yeah.
That was really good. I enjoyed it.
Oh, good. Thank you.
Yeah. And our next speaker is Amanda. So over to you, Amanda.
Okay. Yeah, great presentation, Courtney. I learned a lot. Let's see. I'm going to share my screen. Oh, here we go. Okay, do you guys see my presentation and not my notes?
I see both.
Both. Oh, interesting. Okay, let me do new share. How about now? Okay. I'm sort of new to sharing screens, so. Okay, so again, I'm Amanda Schofield from the Department of Environmental Quality, and I'm going to talk about the environmental side of things. So the environmental impacts of improperly disposing pharmaceuticals, and also DQ's role in trying to mitigate that. All right, so I have a lot on the agenda today, so we'll first go over improper versus responsible disposal. We'll talk about why pharmaceuticals affect the environment, how they enter the environment, and what they can do once they are there. What it means to have pharmaceuticals in our drinking water and ways we can prevent that. And I'll also be talking about OMSDC, the Oklahoma Meds and Sharps Disposal Committee. Okay, so disposal options. We heard from Courtney a little bit about why it's bad to store our medicine. And that's because other household members or household guests can find them and they can abuse them. So we want to try to avoid that as much as possible. The same thing can happen with our pets. They can get into them, and that wouldn't be good. So I'll be talking about what happens when we flush our medicine and what happens when we throw them in the trash. Excuse me, I have this tickle in my throat, so I don't want to cough in your ears. Okay. So yeah, I'll be talking a lot about improper disposal. So sorry. But yeah, before I get too far into improper disposal, I want to clarify what the proper disposal technique is, and that is to use take-back programs. And it's the safest way that we know of to date. Okay, so why do pharmaceuticals affect the environment? So pharmaceuticals are specifically designed to act on living cells. They contain active pharmaceutical ingredients, or APIs. And some examples of what that means is they regulate hormones, regulate metabolic mechanisms, regulate cell-to-cell communication, and they have many other purposes as well. So they're made to act on living cells, and ideally they would act on the cells of whoever they're prescribed to, but that isn't always the case. So they'll act on any cell in the environment that they come into contact with as well. And that's why it's bad. And in addition to containing APIs, they also are designed to be extremely rigid, and that's because when we take them, they first need to pass through our stomachs in order to reach whatever site in the body that they need to go to. And our stomachs are very acidic and very extreme environment that they need to withstand. And so they're made to be very rigid. And that means in the environment, they are going to degrade very, very slowly or even not at all. And when they're in the environment, they are referred to as environmentally persistent pharmaceutical pollutants. Okay, so now we know a little bit about how pharmaceuticals work and why they persist in our environment. So how do they get there in the first place? So there are four main pathways. One is manufacture effluent. Another is improper disposal of unused or expired meds in the hospitals. So we're not gonna go too deep into those two. We're more focused today on proper and improper household disposal. And we'll also talk a little bit about human and animal excretion. Okay, so we're gonna spend some time on this diagram. I think it shows a really nice overview of how pharmaceuticals enter our fresh water supply. So I've highlighted this outer ring here, which represents our fresh water. And fresh water includes groundwater, and which is deep aquifers most of the time, and also surface water, which includes streams, rivers, and lakes. And in Oklahoma and in the rest of the world, we get our drinking water from lakes and aquifers. So we will touch on drinking water later. All right, so we're gonna start first at household pharmaceuticals. The leading source of pharmaceuticals in our fresh water globally comes from urban wastewater. So our toilets, basically. And there are a couple of ways this can occur. One is through excretion. So when we take our meds, our bodies will only absorb the APIs that we need. And if there are excess APIs, they will move through and out of our bodies. And that's not something we have full control over, really. But we can control the fact that we will never flush our medicine again. Because when we flush our medicine, it typically goes to a wastewater treatment plant. And unfortunately, our wastewater treatment plants are not designed to filter out pharmaceuticals in an effective manner. The most common treatment method is chlorination, and that can filter out about 50% of pharmaceutical compounds. And of course, treatment also depends on the physical and chemical properties of each compound, so it's not always exact numbers. So most wastewater treatment plants won't filter out all of the pharmaceuticals, but it is possible. There are more advanced water treatment techniques that can remove up to 99% of pharmaceuticals. And those include ozonation, activated carbon filtration, like reverse osmosis or nanofiltration, as well as advanced oxidation. Please don't ask me what those mean or how those work, because I don't know. But so it is possible, but unfortunately, our wastewater treatment plants aren't designed to use those methods, and it would be an enormous undertaking to change that. It would be extremely expensive, and it's just not being done on a significant scale right now. Another method that I came across, which I thought was very interesting, doing some studies on China on using constructed wetlands for filtering out pharmaceuticals. So I just thought that was really cool. All right, so besides going to the wastewater treatment plant, our urban wastewater can also just go straight into our fresh water, or it can leak out of a septic system. So all kinds of things. All right, so we're still in household pharmaceuticals, and now we're talking about why it's bad to throw our pharmaceuticals away in the garbage. Of course, misuse, our household members or guests can find it and use it. But besides that, our trash will typically go to a landfill. And even though landfills have strict regulation on landfill liners, there still is the potential for landfill liquids to leach out of the landfill and into the environment. The diagram also mentions incineration, and Kima mentioned that as well. So burning our trash. Pharmaceutical compounds have been found in the air, so not good. All right, so moving on to the veterinary side of things. So I mentioned how our pets can get into our meds, and this disposal pathway can be similar to the household, garbage, wastewater. If we have excess medications, we would throw them away. Or again, the pets can get into them and eat them. When pharmaceuticals are applied to animal husbandry, those animals, like us, can excrete those pharmaceutical APIs, and then their manure can be spread as fertilizer. Or, they're in just such tight concentrations, the pharmaceutical compounds can run off as contaminated runoff. So yeah, again, lots of ways that our pharmaceutical compounds are entering our freshwater supply. Not great. So yeah, now we know that they enter our freshwater supply, and this graph, or this image, just shows that this is a worldwide issue. This particular global literature review found 631 different pharmaceuticals in the freshwater of 71 countries. And as you can see, all these countries in gray, there's no data on them, so there could be even more. The United States is the highest consumer of prescription drugs, while Germany is the largest producer. And there are thousands of APIs administered worldwide. The global pharmaceutical market is worth 1.25 trillion US dollars. So it's just a huge industry. The yearly consumption of pharmaceuticals is hundreds of thousands of tons per year for human and animal disease, as well as livestock and aquaculture. So yeah, the concentrations are typically higher in developed countries, and that's just because they participate in the industry more. So very interesting. All right, so moving on. We know that pharmaceuticals can get into the environment, but what do they do when they're there? So one way they affect the environment is through bioconcentration. And this can affect aquatic and topsoil environments. And this typically happens near manufacturers where they dump their effluent. I mentioned that earlier. So sometimes they just dump straight into a river or something like that. This also happens at animal husbandry facilities as well. So once these toxins accumulate in the environment, they also begin to accumulate in animals and organisms. So bioaccumulation, since they don't always break down, they just accumulate in animal tissue. And when they accumulate in animals, this leads to biomagnification. So those toxins increasing up the food chain. And of course, that leads to humans. So more specifics on how they affect wildlife. So microorganisms, pharmaceuticals are typically toxic to them, so they'll just kill them. Some endocrine disruptors inhibit reproduction in fish and crustaceans and in amphibians. And this can move from generation to generation. One example of developmental disruption has been the feminism of fish, and that comes from estrogen found in birth control pills. So that's a really interesting effect. And masculinization can also occur. Antibiotics inhibit growth. Immunosuppressants increase infections, and there have been behavioral changes observed in fish, such as feeding, aggression, and boldness. And so these are just some examples. And of course, aquatic animals often are environmental indicators. So that means that they would be affected first before we see an effect in anything else. So just something to keep in mind. So antimicrobial resistance can also occur, AMR. And pharmaceuticals like antibiotics, antivirals, antifungals, antiparasitics, they encourage this resistance. When they're exposed over and over, they evolve to resist these antibiotics. And when they evolve to be resistant, we call them superbugs. And these superbugs can pass from the environment to animals to people, kind of like biomagnification. So why does this matter? Well, when organisms become resistant, APIs are no longer effective. And that sounds like it could be good for environmental purposes, but for the purposes of curing, diseases and viruses and all of that, it makes all of that really difficult to treat. Okay, so drinking water. I put this map up again just to stress that pharmaceuticals have been found in our freshwater over the entire world. So in the environment, concentrations are about 0.1 microorganisms per liter. And so that's pretty low, which is good for now. And remember that chlorination removes about 50% of pharmaceuticals. So our drinking water, it's more like 0.05 microorganisms per liter and below. Now, since concentrations are so low, humans have not seen an adverse effect. And that is probably why water treatment plants aren't urgently switching up their techniques. But even though concentrations are so low, we know that pharmaceuticals are being produced and distributed and disposed of as we speak every single day on a huge level. So this is a graph that just shows that. It shows the revenue of the worldwide pharmaceutical market, 2001 to 2019, in billions of US dollars. So we can see that the market has grown every single year. So this means that, the concentrations in our environment are only going to rise. All right, so after all of that, I will say that it's important to know that there are knowledge gaps on the exposure to and the effects of environmentally persistent pharmaceutical pollutants. It's a fairly new area of concern, and there's just not a whole lot of research on the subject. And that includes research on the risks of low-level chronic exposure, as well as the risks of early exposure to children, including fetuses, through our drinking water, and the effects of mixed pharmaceuticals. So that's something that, I know we might not think about, but we know what one pharmaceutical is capable of doing, but what does it mean when they're all mixed in together? And there just aren't enough monitoring programs or sampling systems yet. So we have a long way to go on the research side, but there is plenty of research out there, and there is enough to know that this is a problem and that we should be taking preventative measures, which we're doing right now. So education is an important preventative measure. And that's why we're all here today. So this is great. We also know that take back programs are the proper disposal technique. And another nice way to get involved in prevention is through the Oklahoma Meds and Sharps Disposal Committee. So I'll be talking about that next. Okay, so the committee was created a few years back by the Oklahoma Department of Environmental Quality and Product Stewardship Institute. They do great work. They partnered with Courtney as well. She mentioned that. The committee works towards a statewide solution for the safe disposal of unwanted pharmaceuticals, as well as safe medical sharps disposal. So we talked about a little bit in the Q&A how these are like whole different worlds almost. So the committee works on both of those because both of them are big problems. And the committee includes a wide range of stakeholders, such as healthcare professionals, state and local governments, including tribal representatives. Okay, you can't see my notes. Okay. Okay. So I think we were, oh yeah, so wide range of stakeholders. Yeah, we're always looking for more committee members and to widen our range of stakeholders. So we'd love to have anyone join. It's an open group. Our mission is to create a clear and unified disposal message across the state, to document existing disposal options and to identify gaps in infrastructure and to fill in those gaps. And again, we work both on pharmaceuticals and on sharps. So when the group first started, we found some conflicting messaging and we just wanted to clear that up. One example of this was the flush method. So some national organizations provide a flush list, and that would be like, they would include medicines that we can and cannot flush. And we just thought that was confusing for consumers. And we know that flushing leads to pharmaceuticals in the environment and in our drinking water. So we just want to clarify, don't flush at all. So that's just one example of how we are unifying this message. So the large group meets quarterly through Zoom. And there are 2 subcommittees in our group right now, and they meet 2 to 3 times a year. So we have the Education Committee. This committee created and promotes the adoption of our educational messaging. Currently, the committee is working on a social media outreach campaign, and hopefully that will just spread awareness. We want to include information on collection events and just share what we found. There are also these DEA Take Back Days that happen twice a year, I believe. And so those are really good resources. There's also the Infrastructure Committee. And so I say sharps here, but it's actually for both. The Infrastructure Committee created and maintains a database of pharmaceutical drop-off sites, which I'll show you here in a little bit. Currently, the committee is working on best practices for sharps collection programs. Sharps are a bigger issue just because there are currently pharmaceutical drop-off sites and there are not a whole lot of options for sharps. So we're looking into that, and the idea is to create a tool to share what we find and hopefully municipalities will want to start their own Sharps Take Back program. Okay, so this is one example of an educational message that the group created. It's a one-page flyer that informs Oklahomans on how to responsibly dispose of their unwanted pharmaceuticals. It's structured like a stoplight, so we have the ideal option in green and the least ideal option in red. And we did it this way so consumers would have multiple options. The committee considers drop-off as the best option because it's free of charge and because there are already locations throughout the state. We talked about it already. There's law enforcement offices, pharmacies, collection events. So that is an option that's readily available. So mail back is also a take back option. We put it in yellow because there's typically a fee associated with it. And we realize that this may not be accessible to everyone. We do list household garbage on here as the last resort. We recommend crossing out personal information and using a sealable container and mixing the pharmaceuticals with some undesirable substance like kitty litter or used coffee grounds. And that hopefully will discourage people from abusing them or finding them at all. And I know I've been saying this whole time, don't throw away your meds, but we wanted to include this here because we want to give consumers options. And when we realize that not everyone is going to have a drop-off site in their town or the money to send it back. So yeah, and again, landfills do have thick liners and only the potential to leach, whereas we know that flushing definitely leads to pharmaceuticals in the environment. So it is the last resort. We also have a no flush message at the top there in red, blurb on safe storage. So we have to store some of our medicine. We don't want to create stockpiles, but we have to keep the medicine that we want to take. So there are safe ways to do this, like lock boxes or putting them really high up in the highest counter. So yeah, we have some enticing facts on the side. So this is one message we're trying to spread about pharmaceuticals. So feel free to use this, feel free to link to it or share it. I'm pretty sure the OSU Extension Service has already adopted it, so that's great, thank you. We also have a similar one-pager on Sharps that I encourage you all to check out. There is a website for the committee, and you can find these 2 one-pagers, and you can also find the map that I'm going to talk about next on that website. So yeah, here's this map. This is the database that the group created that list pharmaceutical drop-off sites across the state. And it is an interactive map. So I'm gonna just go to that and show you how it works because it's pretty cool. Okay, do you see my browser? Okay, so here's the map. It's a GIS map. So we can come up here to the right and find the legend. So in blue, we have law enforcement facilities. In green, we have pharmacies. In red, we have health services. And in purple is other. And so there's some interesting others. We have senior centers. Up here is a casino. So just interesting to look around. If we move over here to the left, we have some options. So if we push this informational icon, these are the 2 links to those 2 one-pagers. So we just saw this one on meds, and I'll just show you this one on Sharps really quickly, since you asked about it, Jan. So very similar, best options, last resort. Yeah, take a look at that. And then this is really interesting. So if you click on this link, it takes you to a form to fill out. And this is to help us maintain the database. So if you go to this map and you try and visit one of the pharmacies on this map and they no longer exist, or they don't actually have a take back program, then you can fill out this form to let us know, and that'll just help us keep the list up to date. Alternatively, if you know of a site that is not on the list, you can fill out this form to let us know, and we can add it to the map. So good stuff there. If we come over here to this location finder, we can search a lot of different ways. So we can type in a zip code or an address, and we can find all of our options here in Oklahoma City. If we push this home button, it'll zoom us back out. That's convenient. We can also type in a place. So we can type in Oklahoma State University. Right. And it'll take us to Stillwater. And I'm happy to say that Rizuk's Drug Pharmacy is on our map. Yeah, so also if you click on the location, you can find what category it's in, what type it is, the accessibility. Is it open to the public, or do you have to be a member? And you can find the site name, the address, and the phone number. So that's a really nice feature. Another really convenient feature is this filter. Say you know that you need to go to the pharmacy, you know you have something to pick up, and you just want to do this one-stop shop. You want to pick up your new prescription and also dispose of your old one. You can filter out the map to only show pharmacies. So here we see all of the pharmacies on the map. Alternatively, some people might not be comfortable visiting a law enforcement office. So we could filter out the map to exclude law enforcement and just see all of our other options. So very interactive. And yeah, I encourage you guys to check that out. I'll add the link if it's not already there. Let's see. Okay, we're back to my presentation. Okay. All right, so yeah, we hope you are inspired by this committee, and if you want to join, please email. You can email me, or you can email Olivia Dindolk from PSI. The group's pretty active, and we have some good turnout. It started as just discussion a few years back, and it's been exciting to see the group grow and to see these deliverables that we've produced. And if you want to join, you can be as active as you want. You can just read our emails. You can just listen in on the calls. You can interact on the calls. You can join a work group. You can join both work groups. So yeah, up to you. And yeah, that's all I have today. This is a conclusion. We'll go through really quickly. So the most responsible way to dispose of our pharmaceuticals is to use a take-back program. Pharmaceuticals contain APIs that affect living cells, and they're made to be extremely persistent. And that's why they affect our environment. And when they're in the environment, they enter the environment through flushing is the most common way, and also household garbage. And they affect our wildlife, our ecosystems, our drinking water. If you want to take action, you can, I know you guys are going to go on to educate some people about this. You can tell your friends, your family. You can join OMSDC. And there is my email again if you want. I also have references if you would like them. So thank you.
Thank you, Amanda. Any questions for Amanda? And the OMSD group is actually a good one. I am part of that committee. They are pretty active, like Amanda said. So it will be a good community to join if you're interested in doing work with prescription medication and jobs in your county. So feel free to reach out to Amanda.
Yeah, and if you're interested in helping your local pharmacy get more involved, you could send them over to us as well. That'd be a good way to inform them.
Could you share the link to how to get to that map again?
Yeah, let me stop sharing. Okay, so it looks like Kima added the link to the group, and I'll just add the link that goes directly to the map. And then I'll also add the link that goes directly to the Sharps one-pager. There you go.
Okay. All right. Okay. Thank you, Susie. She said the interactive map is awesome.
Yay. I hope it gets some good use.
Yeah. Okay, so let me share my screen. So pretty much next I will just be talking about available resources, which Amanda and Courtney have talked more about. So pretty much it'll just be a recap. So there, we have a lot of resources. There are a lot of resources out there. Instead of disposing of your medication in your household trash just like that, or maybe burning them, which might impact the environment. And we've heard from Amanda some environmental concern, and as well as we've heard from Courtney about some of the impact it might create. So there are a lot of options. Both Amanda and Courtney mentioned about the take back programs. This kind of program provide opportunity for communities to have a drop boxes wherein you can safely take your medication, and these medications will be properly disposed of. This kind of method is safe and most preferred and environmentally friendly. So always make use of opportunities like that. And Courtney mentioned about the Oklahoma Bureau of Narcotics Safe Strip for Script program. They have their also like a take back location finder in there. So basically you enter your zip code and things like that. It will also show you like law enforcement locations and take back boxes near you. So the link is also there. I will share it after the presentation. And if, like they were saying, if you need more information, it's always good to reach out to your local pharmacy or your local sheriff's office. And There is also a lot of resources on the product stewardship website. You visit there and you'll get a lot of information. And Amanda obviously talk about this map. They have this map there that you can interact with. And the other opportunity you might want to take advantage of there is the DEA Take Back Day event, which is a nationally recognized day to create more awareness on drug abuse, drug misuse, and as well as the safe disposal of unused and expired medication. So they organize this event like two times in a year, wherein they provide a temporary drop boxes at specific locations. So I would say watch out for those kind of events. It might be organized by your city or maybe your pharmacy or clinic, or watch out for events like that. And also some cities during their hazardous waste collection events, they might decide to collect prescription medication, expired prescription medication. I will also say grab those opportunities and make use of them. Always check out with them to see if there is anything going on about med collection or events. And the medicine mail back program, Amanda also mentioned about that. This type of collection will require some fee. So I would say we go for those that are free, and but always check out with your local pharmacy on these and clinics and health centers and see what's there available. It's also easy, even though you are paying money, but you can just simply just mail it out and they get it disposed of it. And you can also do it at home using your coffee grounds and things like that. Instead of just putting it like that in your trash, which might get to your kids or maybe your pets and things like that, you can easily mix them with one of those items and put them in a Ziploc bag and safely dispose of it in your household trash. So there are a lot of resources out there that you can make use of. We have provided some links. And Courtney, I don't know if you have any link that you think we can also share with the educators that they can benefit from, but yeah.
There were several different things. I can definitely send out some references for different things I found, depending on what you're interested in.
Okay. So let me start sharing. So that is all basically I have for you guys. So I'm sending in the link for the Take Box Finder there, Dropbox Finder. If you have any more questions for me, or any questions for Courtney and Amanda, or anything that we can discuss, then we're open for that. Anything at all? Okay, then that comes to the end. Thank you, Amanda and Courtney. I really appreciate you making time to educate us all about opportunities that are out there. I really enjoyed all your presentations, and I learned a lot from the both of you. Thank you, and thank you for everyone for joining, and have a wonderful day.
Thank you.
Thank you.
All right, bye-bye.
Thanks.